Hello, class. Welcome to Flourish Nursing Academy. This is Tutor Godwin. We'll be discussing gastroesophageal reflux disease. The esophagus is a mucus-lined muscular tube to carry the food materials to the stomach. Gastric acid helps in the digestion process. The lower esophageal sphincter, LES, controls the passage of food materials from the esophagus to the stomach. Abnormal opening of the LES will lead to reflux of gastric acid. Gastroesophageal reflux disease is a chronic and relapsing condition in which prolonged reflux of hydrochloric acid, pepsin, and bile salts into the esophagus, oral cavity, and respiratory system leads to esophagitis. The pathological consequences of involuntary passages of gastric content into the esophagus. Esophageal mucosal damage produced by abnormal reflux of gastric contents into the esophagus. Incidence and prevalence. The prevalence rate of GERD in India is 8% to 20% of the population. Age: older adults are commonly affected. Incidence of late adolescents and young adults is also high in number. Sex: except for pregnant mothers, both sexes are equally affected. Gastroesophageal reflux disease, GERD, can be classified based on its severity and symptoms. Classification based on severity. 1. Mild GERD. Symptoms occur infrequently, and lifestyle modifications can often manage them. 2. Moderate GERD. Symptoms occur regularly, and medication may be needed to control them. 3. Severe GERD. Symptoms are frequent and severe, often requiring long-term medication or surgery. Classification based on symptoms. 1. Non-erosive reflux disease. NERD. Symptoms occur without visible esophageal damage. 2. Erosive esophagitis. Symptoms occur with visible esophageal damage, such as erosions or ulcers. Other classifications. 1. Acid reflux. Stomach acid flows back into the esophagus, causing symptoms. 2. Non-acid reflux. Non-acidic stomach contents flow back into the esophagus, causing symptoms. Grade A. One or more mucosal breaks, erosions or ulcers, in the esophagus, each less than 5 millimeters long, that do not extend across the tops of 2 mucosal folds. Grade B. One or more mucosal breaks, greater than 5 millimeters long, but still not extending across the tops of 2 mucosal folds. Grade C. Mucosal breaks that are continuous and extend between the tops of 2 or more mucosal folds, but involve less than 75% of the esophageal circumference. Grade D. Mucosal breaks involving 75% or more of the esophageal circumference. Causes of GERD 1. Lower esophageal sphincter, LES, dysfunction. Weakness or relaxation of the LES allows stomach acid to flow back into the esophagus. 2. Hiatal hernia, a condition where the stomach bulges up into the chest, potentially weakening the LES. Risk factors of GERD. 1. Obesity. Excess weight can increase pressure on the stomach, causing acid reflux. 2. Diet. Consuming trigger foods like citrus fruits, tomatoes, chocolate, or spicy foods can exacerbate symptoms. 3. Smoking. Smoking can weaken the LES and reduce saliva production, which helps neutralize stomach acid. 4. Certain medications. Medications like sedatives, antidepressants, or antihistamines can relax the LES or slow digestion. 5. Pregnancy. Hormonal changes and increased pressure on the stomach during pregnancy can lead to GERD symptoms. 6. Delayed gastric emptying. Conditions like gastroparesis can slow digestion, increasing the risk of acid reflux. Lifestyle factors. 1. Eating large meals. Consuming large meals can put pressure on the LES. 2. Lying down after eating. Lying down after eating can cause stomach acid to flow more easily into the esophagus. 3. Wearing tight clothing. Tight clothing can put pressure on the stomach, exacerbating symptoms. Risk factors associated disease conditions. 1. Barrett's esophagus. 2. Scleroderma. 3. Asthma and COPD. 4. Diabetes mellitus. 5. Celiac disease. 6. Hormone replacement therapy. A hiatal hernia can contribute to gastroesophageal reflux disease, GERD, by disrupting the normal function of the lower esophageal sphincter, LES, and impairing esophageal clearance. This leads to increased frequency and duration of reflux episodes, causing irritation and damage to the esophageal lining. Difference between hiatal hernia and GERD. Hiatal hernia versus GERD 1. Disrupted anti-reflux barrier. The gastroesophageal junction, where the esophagus meets the stomach, acts as a barrier to prevent stomach acid from flowing back into the esophagus. A hiatal hernia, where part of the stomach protrudes through the diaphragm into the chest, disrupts this barrier. This disruption includes reduced LES pressure. The LES, a muscle that normally keeps the junction closed, weakens. Increased transient LES relaxations. The LES relaxes more frequently and for longer periods, allowing reflux to occur. Impaired esophageal clearance. Acid that refluxes into the esophagus is not cleared efficiently, leading to prolonged exposure to stomach acid. 2. Increased reflux frequency and duration. The weakened LES and impaired clearance mechanisms lead to more frequent and prolonged episodes of gastric contents refluxing into the esophagus. This is particularly noticeable after meals when the stomach is full and during nighttime when the LES naturally relaxes. 3. Esophageal damage. The repeated exposure of the esophageal lining to stomach acid, which is acidic, can cause inflammation and irritation and potentially damage the delicate tissues. This damage can lead to symptoms like heartburn, chest pain, and difficulty swallowing. In some cases, prolonged exposure can lead to more serious complications, such as esophagitis, Barrett's esophagus, or even esophageal cancer. Clinical manifestations: oesophageal, heartburn, dysphagia, odynophagia, regurgitation, belching, alarming symptoms, dysphagia, early satiety, GI bleeding, odynophagia, vomiting, unexplained weight loss, iron deficiency, anemia, choking, continual pain. Diagnostic evaluation history collection, genetic influences, dietary pattern, type of food, mealtime, activities immediately after a meal, medication history, history of presenting symptoms, duration, aggravating and alleviating factors, physical examination, weight loss, dysphagia, heartburn, barium swallow test. Rule out the presence of a hiatal hernia or esophagitis. Endoscopy. In case of alarming symptoms, immediate indication for endoscopy. Identify the grade of GERD. Esophago. Gastroduodenoscopy. Allows for the detection, stratification, and management of esophageal manifestations or complications of GERD. Physiological study. 24-hour pH monitoring. Accepted standard for establishing or excluding the presence of GERD for those patients who do not have mucosal changes. Esophageal manometry. Assess ELES pressure, location, and relaxation. Assist placement of a 24-hour catheter. Assess peristalsis before anti-reflux surgery. Management endoscopic therapy. Rapid radiofrequency energy delivered to the LES, Stretta procedure. Suture ligation of the cardia. Endoscopic fundoplication. Submucosal implantation of inert material in the region of the lower esophageal sphincter. Enterix, the gastric fundus, upper part of the stomach, is wrapped around the lower end of the esophagus and stitched in place, reinforcing the closing function of the lower esophageal sphincter. Complications: erosive oesophagitis. Acid irritation and inflammation can injure the esophagus over time, creating a condition known as erosive oesophagitis. Stricture: abnormal narrowing of the esophageal lumen, Barrett's esophagus. Abnormal, metaplastic, change in the mucosal cells lining the lower portion of the esophagus. Adenocarcinoma. Nursing management. Acute pain in the epigastric region related to an inflammatory process in the esophagus, as evidenced by the pain scale score. Imbalanced nutrition is less than the body's requirement, related to difficulty in swallowing secondary to esophageal irritation, as evidenced by verbalization. Chest discomfort related to irritation of the esophagus, secondary to backflow of gastric contents, as evidenced by verbalization and refusal to take food. Nausea related to delayed gastric emptying, as evidenced by verbalization. Risk for bleeding related to esophageal mucosal damage. Risk for aspiration related to recurrent gastric regurgitation. Ineffective airway clearance related to backflow of gastric content into the upper respiratory tract, as evidenced by cough and verbalization of hoarseness of voice. Nursing measures: assess the pain level of the patient. Maintain the input and output chart strictly. Avoid exposure to mucosal irritants. Check for the symptoms of bleeding. Give health education on lifestyle modification measures. Fluid replacement therapy is needed. Follow the chart of foods to be added, avoided. Elevate the head end of the bed to a 45-degree angle. Follow the measures in the bedtime meals. Do not take food for 2 to 3 hours before bedtime. Avoid snacks at bedtime. Avoid fatty or oily foods. Avoid caffeinated beverages.